Welcome, everyone. I am Jennifer Mays, and I'm one of the co-directors of the National Center for Child Traumatic Stress at UCLA and Duke University.
And I'm Lisa Maya Jackson, also a co-director at the National Center, and we are here for another episode of our co-director download series.
Yes, and this is a series where we interview leaders in the National Child Traumatic Stress Network.
And today we are lucky to have Nancy Kassam-Adams and Ann Kazak with us. Welcome, Nancy and Ann.
Good to be here.
Thank you. Nancy Kassam-Adams and Ann Kazak are co-directors of the Center for Pediatric Traumatic Stress, which is an NCTSN Category II Center, and they've both been part of the network since 2002. Nancy is Associate Director for Behavioral Research at the Center for Injury Research and Prevention at Children's Hospital of Philadelphia and Research Professor of Pediatrics at the University of Pennsylvania Perelman School of Medicine. And Ann is Director of the Center for Healthcare Delivery Science at Nemours Children's Health System, which is part of AI DuPont Hospital for Children in Wilmington, Delaware, and she is Professor of Pediatrics at Jefferson Medical School of Thomas Jefferson University and Adjunct Professor of Psychology at the University of Delaware. I do want to add that Nancy and Ann have played numerous leadership roles in the network over the years, as well as in the wider child trauma field, as part of the steering committee, as leaders in our integrated care collaborative group, and on many other projects and initiatives. So again, welcome to you both.
Wonderful to have you both here. Let's start at the beginning. How did you both get interested in the field of child traumatic stress?
Well, I guess I can start. I actually came to child trauma through other kinds of trauma. So back in the day, I was a master's trained therapist and worked in domestic violence, family violence, and sexual assault agencies in the city of Baltimore. And ended up going back to school to get a PhD in psychology. And along the way, continued that interest in traumatic stress and ended up doing my internship at a children's hospital, where I discovered that, you know, the kids coming to the hospital were really an amazing population. It was an amazing time and amazing opportunity to make a difference in kids' lives. So I came at it first from a broader traumatic stress interest and lens, and ended up applying that in a pediatric medical setting. That's kind of how I got to where I am. And then my research home has been in an injury research center, as Jen mentioned. And so injury also is a great example of sort of an acute medical trauma, and hence my interest in injury and medical emergencies for kids with the traumatic stress lens.
Yeah, my background is in clinical and community psychology, and I was always particularly interested in how children and families handle difficult, challenging situations. I ended up, you know, working in a children's hospital, which was a great opportunity, and particularly was focusing on children with cancer and their families at a time when kids were actually beginning to survive cancer at a much higher rate. This was really good news. And the medical teams that I was working with were interested in, well, what's the psychological impact of that? And some of the first studies were basically saying, oh, you know, they look really great, you know, everything's fine. And I wanted to believe that, and I still believe that in many cases, but I also knew that there had to be something more, you know, to go through a life-threatening illness. And so I was really looking for ways of understanding that experience, and was zeroing in on trauma. And a nurse practitioner at Children's Hospital of Philadelphia, where I worked at the time, said, you know, there's a psychiatrist at UCLA who's interested in the same thing that you are. And through her, got connected with Margie Stuber, and we did some of the initial studies about basically using a trauma framework for understanding the experience of kids and families. And, you know, it's taken off from there in many different directions.
Yeah, I think it's interesting to remember that, you know, back in the 80s, 90s, when I was working as a therapist, for example, at a sexual assault center, we were talking about rape trauma syndrome. And at the Family Violence Agency, we were talking about battered women syndrome. And there were these people we knew working with Vietnam vets talking about PTSD. And, you know, Anne in that similar kind of era was in children's hospital. And that, you know, back then we didn't necessarily put all that together. It was just the turning point, I think, in thinking that there were some similarities across these different kinds of, certainly differences, but similarities across these different kinds of experiences, and that a trauma lens was so helpful. Something you've said before is that it's a good frame for a competence-based sort of framework. Mm-hmm. That it's not that you're crazy to have these responses when these things happen to you, whatever they are, violence or right. You know, a really difficult medical experience. It's a very understandable distress response to a really difficult situation, and that it's a great basis for helping people understand.
Yeah, that's true. I mean, when you think about it, I think we initiated the war on cancer in the 1960s. We're still fighting it, if you will. A lot of people don't like that analogy, but I think there's a reasonable amount of validity to it. And certainly when you talk to kids and families and people and you use those kind of analogies, people get it. Of course I have traumatic stress. I've been mm-hmm. through these horrific experiences. Mm-hmm. So that does lead, I think it really opens people up a lot more than sort of saying, mm-hmm. Are you depressed? Are you anxious? But to more say, yeah, that resonates with the experiences we've had.
I think we've heard that particularly from dads from time to time, right? Yes. That's an analogy or a framework that works for them. Mm-hmm. To understand why their kid's illness or injury are really frightening, either sort of single incident medical thing or sustained scary medical thing, why it's had such an impact on them. Yeah. And that it's a framework that works for them.
Right. So. And so the way Nancy and I got connected was we worked in the same hospital system, so we did know each other, but we're working in very different areas, and we were approached by a social worker working in the pediatric intensive care unit at the PICU, who I guess had maybe read our work or heard, through the grapevine that what we were up to, and said that he thinks that this is really relevant in the PICU. And so we did a study in the PICU, and the PICU is really where kids with injuries may end up, kids with cancer may end up, kids with other types of, serious and life-threatening circumstances may end up. And so that was really the first beginning of the Center for Pediatric Traumatic Stress was when we did this study together and what we think of as the crossroads of trauma mm-hmm. in the hospital. Mm-hmm.
Yep. All right, well, maybe we can pick up there to ask our next question, which is what first drew you to the NCTSN, or how did you both sort of get started in the NCTSN, and if you want to take it further to talk about sort of what has sustained your involvement in the network and commitment to the network, and how do you see the network having kind of influenced your trajectory of what you're both doing?
Well, we were there when it started, I guess. I remember being very excited when the call for applications came out, and we talked and sort of said this might be a wonderful opportunity, and we at that time were really, I think, quite unique in terms of looking at medically related traumas. And we didn't know what would happen with that, because it was very different from some of the things you think about in terms of child abuse or family violence or even natural disasters, just very different type of trauma. But it was very exciting to work on that application and to put to put it in, and to really I remember some of the first meetings and encounters with people in the network to sort of look around and say, wow, these are really like all the major figures in childhood trauma, and was just a great honor and opportunity for us to I think to really help define this area of medical trauma, mm-hmm. which I'm pleased to see, is represented now by an increasing number of centers and programs.
Yeah, and one of those early, so there was another center funded in that first cohort. We were sort of cohort 1.5 in that first cohort with Glenn Sachs, who did both medical and refugee trauma. in a single center. And so that was wonderful to have his collaboration, and we collaborated really closely. And there was a medical trauma working group that was in existence in those early days. And an example of a network initiative that turned into something that has sustained all this time is there was a, what's it called, accelerated something projects, accelerated collaborative projects. We put in an application, we got funded or approved to do that, and you had to turn them around in 8 months or something like that. And that was, because of that, we had an in-person meeting of the medical trauma working group, conceptualized this idea of a pediatric traumatic stress toolkit. And out of that meeting grew this idea of the DEF framework. The idea of, medical folks need quick 3-letter acronyms. So I think this was actually Glenn's initial thought of distress, emotional support in the family. A number of tools got created out of that particular network initiative that have evolved over the years, certainly, but that form a framework that I think still has stood us well over the years. Yeah. I think that we're very happy that there are other centers that are focusing on healthcare settings, and really have had great, both with the Hopkins Center starting in, was it 2 funding cycles ago? It all begins to run together. And now with like 3 others, I think we are still unique in focusing on secondary and tertiary care. So sort of the emergency department, the hospital, subspecialty care, and on medical things as the traumatic event. But it's been really wonderful to partner with folks who have more of a focus on primary care and thinking about what it means to integrate trauma and being trauma informed in a primary care setting. I think those centers, those Category II centers that work in this area really complement each other very nicely, each with a slightly different focus.
You and your teams have made such an important mark on the NCTSN. You really have been pioneers, and you have continued to be involved with the collaborations across the network around with integrated care. And we're just so grateful to you also for your leadership in the issues around COVID and all you have done in those areas. So just thank you so much for that. And so, I'm going to flip it over to the question now of how has being part of this national network impacted your community and your work?
Well, I think it's been very helpful, particularly over time, because a lot of what we do focuses on training multidisciplinary healthcare providers. And so I think, increasingly the appreciation for the challenges of working day in and day out with kids and families who may have challenging medical conditions, but may also be bringing a lot of other traumas into the healthcare setting. So I think the network has really given us, a platform, if you will, for pushing out a training, which we can specialize and specify for various different types of providers or settings. And I think, this is particularly, in a COVID environment, we were able to pivot, very quickly with a lot of our materials to reach out and to have some, ability to push those resources out and hope that they've been helpful to people, particularly as this becomes much more of a chronic situation rather than just an acute one. We're proud of our website, which is healthcaretoolbox.org, and hope that also has become a resource for people, and something that, again, without the network, we wouldn't have that. Without the network, we wouldn't have the ability to sort of continually remind people or further develop and refine the way that we have materials provided.
I think we've always been focused on doing things that are on having at least a part of our sort of portfolio be having things that are very web-based and accessible. So online training courses for nurses, easily downloadable handouts for patients and families, those kinds of things that healthcare providers can easily make use of. And that's is a good place to be when everything goes virtual, certainly in these times. But we're thinking about reach and being able to reach, every healthcare setting across the country, ideally. We knew that we needed to be online and to have things be very simple to get a hold on. So we certainly do in-person training, and we help other people do in-person training, and we help people do that within their settings. And but we also have a lot of things where you might be a lone healthcare provider interested in this topic. You can go to our website and find a lot of resources, and find a way to maybe to become a champion in your setting. Definitely. The other thing for me around the network that's been really useful over the years, and I know I see this across our team, is this idea of thinking across different service systems. We're often really, really aware that we're in quite a different service system from other network members when we talk about sort of mental health treatment or, child welfare systems, which I think are sort of the most common maybe types of settings. So that can be a challenge, but it's also this opportunity, to think like, what are the core things that hold true or that might need to be different if you're in a mental health system, if you're in the courts or juvenile justice or healthcare system. I mean, it's been really useful for us to get clearer about what we need to do to translate this stuff or to create it from scratch within healthcare systems.
Yeah, and I think another thing is sometimes we think about our center as being a dissemination and implementation branch of the work that we do. So, research grants will fund something that hopefully when you're developing it, certainly when you're testing it, but oftentimes, the funding is not there when it comes time to say, hey, we've got this idea, we've got something we've developed. Do you want to use it? Can you tell us about how your use is? So that's been very helpful for a number of our interventional materials, is to have a framework by which we can make things available to people and learn about how to really make sure things have traction.
Right. I mean, because of this work, we're able, for example, like thinking the psychosocial assessment tool as an example of a PAT, that gets distributed, it's disseminated to healthcare settings around the country and even outside the US. But because of this, we're able to sort of track who is it being used for, de-identified data comes back, so we know how many. These are essentially what it's for, is to track the psychosocial needs, trauma as well as other things of kids in various medical settings, mostly hospital-based. But we get this high-level data back about sort of the levels of risk that are being seen, and so it's really, really useful for those settings. It helps create benchmarks, and that's really all possible because of this kind of funding. So.
Well, maybe for our last question, we'll ask you to sort of look forward a little bit in terms of thinking about how, you're both, what you've both been describing about all of your years and experience in the field and in the network is really, I think, highlights the importance of collaboration and all of these interconnections within the network, which has been a critical, foundation for the NCTSN. And so we'd like to give you a chance to share any thoughts about how the network might continue to kind of keep this collaborative spirit alive, to keep working together even as we're growing bigger and the field is growing more complex, and just sort of what sort of thoughts you have maybe about the future for the network.
I guess, I think that the long history of both formal and informal collaborative work groups of various sorts, whatever they're called, at different eras of the network, I think really speaks to that. Certainly I've been part of groups where it feels a little bit like I'm just ticking a box and attending a call once a month, but the best of them are, really sharing interests, hearing what everyone else is doing, and then actually digging into projects together. And I think that's useful both in work groups where we really have strongly overlapping shared work and interests, but it's also been useful for just keeping an eye on things that are just a little more further afield. Back in the day, for example, there was an acute interventions work group that was really across many settings, but all about those sort of early days after a trauma. Currently, and some interesting things came out of that. The Integrated care work group is a great example of one that's, we're sharing the notion of working in healthcare settings and what does it mean to be trauma informed in those healthcare settings. So I think that kind of thing that gives us tasks to do together is probably the best way of staying in touch, and easier to do virtually as needed.
Yeah, and I agree with that. I think that too, Nancy, it's something you said a little while back about working across systems and, you know, increasingly think about, I mean, I think we've always been very, very concerned and very focused on making sure that kids that are in healthcare settings are, you know, are understood from a trauma lens as necessary, but also kids don't just visit one system, right? I mean, they move around the whole social ecology. And so I think thinking about ways to make sure our conceptualization and our interventions and our evaluations, you know, continue to keep an eye on multi-system work.
Well, thank you both for taking the time out to chat with us today.
So appreciative. We definitely have helped our NCTSN culture to be what it is. You know, it's all about collaboration and respect and sharing. And I just speak for both of us with gratitude for all you have done and how fun it is to get to talk to you today. Thank you.
Yeah.
Great.
Thank you.
Thank you.